Good afternoon, good morning, everyone. Mid-morning. Delighted to welcome you to our second session, building social prescribing networks, best practices and strategies from around the world. And we do have a global audience and a global panel today. I'm delighted to welcome Camila, Cristina, Heidi, and Lee, and we'll do short introductions just now. But let me set the context here. We really do need to ensure that we build these social prescribing networks at the local level and empower local people to become part of the process. That's critical for adoption. And I'm sure our panelists will take us into a deep dive. So without further ado, let me bring in Camila for a short introduction, who's in Colombia, I think, at the moment. So Camila, it's a pleasure to welcome you.
Hi, everyone. Good morning. Thank you, Garrett, for having us here and this amazing co-panelist. I am part of Fundación Queralty in Colombia and Queralty Compassionate Communities in the U.S. We work around community-based health solutions, and we work in empowering community members to become signposters or do social prescribing at the local level. But we're also part of a global healthcare organization called Queralty. We are in 9 countries. And we believe that doing true healthcare should involve doing social prescribing, connecting with local resources, understanding the true needs of patients. So we have embedded social prescribing into our primary care facilities, both in Colombia and in Florida, where we have our major operation in the US, and also at our hospital level. Achieving, well, in Colombia, we care for about 6 million people. And so we're trying to reach all of them through social prescribing, not that easy, but we're moving forward, and we have been doing it for the last 5 years. Thank you.
Thanks, Camila. Thanks, Camila. Let me bring in Heidi.
Hey, Gareth. Good morning. And it's a real honor to be here and to be among so many great innovators in this space. So really delighted, and thanks for the invitation. So I'm Heidi Albert. I'm the head of the Cities Health Center at ICLEI, and we're a global network of cities for sustainable development. I'm based at our African Secretariat in Cape Town, South Africa. And ICLEI, we have a network of over 2,500 member cities and subnational governments around the world, and we work with them to support multi-sectoral urban development. So we really see social prescribing as a really key element of promoting health and well-being among urban communities. So really excited to collaborate around this and see how we can bring this innovation across our member cities around the world.
Fantastic, Heidi. And let me bring Cristina. I'm delighted Lameck has joined us as well, based in Kenya. So, hi, Cristina.
Hi. Thank you very much. It's a huge honor to be here, Garrett, with Luis. My name is Cristina Vaz de Almeida. I am the president of Portuguese Society of Health Literacy. We are working several years from now in social prescribing, and we have several projects, including in the National Plan of Elderly. So it's a huge pleasure to be here and to share some ideas about this. Thank you very much.
Thanks, Cristina. Lee, come to you.
Hi, Gareth, everyone. Firstly, thanks, Gareth, for organising this summit. It's a pleasure to be here. My name's Lee Whitehead. I lead an organisation called Smart Social in the UK, and we do a bit of work across Europe. We bring social investment into a range of prevention and social prescribing projects. And I've been looking at and researching a number in the UK and globally. And I'll be talking about that. But my primary interest today is to understand how investment can come into it. Investment, alternative investment, not public funds, bringing that into social prescribing from corporates and other funding institutions.
Thanks, and that's why I want to bring Lameck in next, because Lameck can give us some insight into sort of that impact. I've been working with Lameck on a number of projects that we have in the pipeline to support very vulnerable communities across Africa. Lameck, the floor is yours. A short intro.
Okay, thank you so much, Gareth. I'm very much happy to join this conference, and I want to thank you and appreciate your effort to put together this conference. My name is Lameck, as mentioned by Gareth. I'm the lead at AFIA for Africa. It's a grassroots organization working closely with the community. And we focus on 4 thematic areas, that is health, environment, gender, and education. And I'm happy that this conference is focusing on social prescribing, whereby our focus as an organization is also pegged in. I'm looking forward to learn a lot from most of the presenters, and as we continue. Thank you so much, Gareth.
Pleasure, Lameck. And so I think it's great that you can get a kind of flavor of the international audience that we have here and the panelists, and we'll be able to take a deep dive, and then myself and Lee as well can articulate how we bring the financial resources to ensure that we actually deliver on the impact and the importance of working collaboratively with honesty and integrity and trusting each other. I think that's what's paramount here. So let me just come to Camila first. Camila, we the topic is building social prescribing networks, and you guys are an experts in this space, and particularly around best practices and strategies. You're doing it, not just in the US, and in Colombia and Latin America, but around the world. Can you give us what are the critical sort of first steps when establishing a social prescribing network in a region?
I mean, I think one of the biggest challenges, and it goes, of course, linked to the first steps, is the fact that I think, especially in countries like us in South America, at least I've seen it a lot, social prescribing is not even a conversation yet. And so I think that was like one of the key components that we start putting on the table on the conversation, why social prescribing is relevant, and how it can impact, the work that you do at every level. As I said, I'm part of a healthcare organization. So for us, even for me, it was the first challenge was doing it within the infrastructure. I think one of the critical steps was actually having access to data, resources around what has been done and what has worked around the world. So you can start sort of showing the no believers that this can happen and how it can impact. I also think having, examples of how to do it, because, when you're the one saying that we should do this and let's make up a strategy. And I actually had to create sort of like a go by ear strategy here in Colombia when I started. Gladly it worked, but it could have not worked. And then I would have lost sort of that impulse. So I think one of the key issues is having resources and, access to information so we can share and make everyone aware of how it works and why it works. I think that's crucial. And I think being part of networks like this one really does help in that sense. I think the other thing is trying to set on the table a lot of people. Social prescribing is not just healthcare. It's not just social services. It isn't just about the community. It is about all the players that need to start working together in a very siloed type of world that we live in. And so I think one of the crucial things for us was sitting everyone at the table. And even us being a healthcare organization or part of a healthcare organization, I think it was crucial that we sat other key players of the healthcare system in Colombia at the table. And it wasn't just Keraldi. It was a conversation with other insurers and other providers so that we all saw that this would benefit us as a whole and as a system, not just as one company would be benefited from this. Empowering community, I think working with the community, and I think that's why my role as a nonprofit was crucial in terms of how to sort of bridge that gap between different organizations, because I was able to sit down and talk to the community. I was already doing it and doing social prescribing at the local level. But then I could also talk from a different perspective to the social sector, to the healthcare sector, and then sort of bring a lot of people to the table and understand how we are all key players in that sense. So I, like in a nutshell, I would say having access to resources and information and data, sitting everyone at the table and understanding that this isn't just for benefit or one or the other, but of everyone, and empowering the community so that we understand that health actually does happen at the community level. And so we can't pretend to play this game if we're not sitting down with the community and understanding what they truly need, so that we actually do a social prescribing that is benefiting everyone in the community and not just what we think.
Completely agree, and that's why we have a playbook. We actually we developed a playbook with 30 countries actually. The Global Social Prescribing Alliance. It's available. You can download it free off our website. We have a number of tools that are there. There's also further tools in the pipeline. We're working on a number of educational tools. We have a global roadmap for link workers that we're developing. So all of those will be available online. I think I just wanted to come to Heidi. Because we've got an enormous opportunity. Sorry, let me bring Heidi in. In terms of, ICLEI, the work that we've been working on nature-based solutions. I've been working with your colleagues for a number of years now, but we're starting to kind of crystallize and get down dirty and then sort of get into the community settings. For some reason I've come back in there. How do you ensure collaboration across sectors, healthcare, education, community organization, while building networks? I mean, you guys are experts in this because you do it over such a vast area.
Yeah, thanks, Gareth. Absolutely. I mean, I think the question of how to build this collaboration across sectors, it's a common thread, as you say, across all the work that we do as ICLEI. So I think it's across all the different sectors at the city level, and it's also multi-level in terms of from national to regional to local. And so through our work, I think we see that the cities and the local governments are really ideally positioned to be the ones taking a leadership role in this kind of collaborative approach. They're able to convene across multiple different sectors, as you mentioned, across, in this case, healthcare, education, community, also the environment. As you mentioned, as ICLEI, we are particularly interested in nature-based green social prescribing. And really, they're very close also to the communities that they're serving in terms of being that very local level of government. So I think seeing that local action and that local convening across the stakeholders, I think is really, really critical. But it doesn't just happen, in a vacuum. So it needs to have the right support, the right investment, and those different connections at that level across the different sectors, but also sort of up and down. And I think just building on what Camila was just saying as well, I think, we're very used to talking about co-creation, but we really need to have a true co-creation that counts the communities and the stakeholders as equal partners. So they're not just the recipients in this, but they're the ones who really understand, their local context, what is needed. And certainly looking across a country and even within one city, there's such a diverse set of contexts and needs and solutions and capacity that, we really need to take this very micro sort of granular approach. And I think as ICLEI, just one sort of concrete example, I think also we are very involved across our many sort of areas of work with also sort of convening these city networks across kind of global platforms or sometimes regional platforms. So this peer learning, and I think Camila was alluding to, really seeing concrete examples, practical examples of how other cities have sort of actually actioned these sort of initiatives, sort of takes it from something quite theoretical to something that they can really engage with. So we see that as being hugely valuable to drive this sort of collaboration. I think we'll hear later about the financing, but I think, collaboration is only sustainable when it's properly financed and it's bringing together all the different actors and making sure that their needs financially and otherwise are being met. And then I think maybe just another piece I wanted to mention, I think it links to that financing, is we also need to be measuring what matters to the different stakeholders and the different sectors. So I think sometimes, we're demonstrating impact in one particular way, but maybe that's not speaking to the needs of the different sectors that we're aiming to collaborate with. And so, it's not just about the clinical outcomes, it's what about access, what about equity, nature-based solutions, how can we also sort of measure the impact on the environment, on community, etc. So I think we need to be really listening to all the different stakeholders that we're collaborating with and making sure that, everyone's needs are being addressed in a really holistic way. Let me maybe pause there.
Yeah, fabulous. And you mentioned the financial side and the local, the local engagement and ensuring that we have the impact, engaging the communities. I'm sure that's music to your ears, Lee. Let me bring you in so that we can have a discussion about how do we take this forward. I think, Heidi's point about making it sustainable is absolutely crucial. So, what lessons have you learned about sustainability and funding of these networks? And then the second point that I want you to cover is, what do you think the socioeconomic metrics demonstrate in value? Because that makes it sustainable.
Me away from the political statements, which I try to avoid. So here in the UK and across Europe, and there's only a few countries that I believe probably have sufficient taxation principles to fully fund their health and social care systems. And even then, they're under pressure. Certainly in most countries throughout the world, there is an inundation or a greater demand for their health and social care than they can possibly ever deliver. And a lot of our systems are finding that, increasingly so over recent years, maybe as funding has been reduced. So I'll stop the political statements there. So prevention becomes a major factor in how you manage demand and manage your health and social care. And I was pleased to hear Cristina say that I think this also feeds across into education and family and justice. Social prescribing isn't just a health and social care issue, but let's look at that at this point. So, there have been, and I come from a social impact perspective, there has been 10 UK social impact or social outcome partnerships that specifically have invested into social prescribing. There's about 50 globally. So I've done some research in this and looked at what they've been doing, and it is various, as you'd expect, as varied as the commentaries we've heard this morning. But I can say certain social prescribing impact models or innovation models have things in common when they're successful, and that is that they have a very clear understanding of system change. And I'm a big advocate of human learning systems being stewarded and delivered with leadership at the front. It's very clearly linked to the idea that prevention and earlier intervention is better than people using high cost, high level health and social care. We've already heard it. One of the most success dominating factors is co-production with local people, and local being the word there. You have to work and co-produce your models of social prescribing with those that are going to use it. And finally, I think the best agencies to run social prescribing projects are non-profit, voluntary sector charities in the UK, because they are very much in touch with their local areas. So the sustaining of social prescribing has to have those three things in it, which are that, we start with a system change, a system way of understanding that we're going to prevent, and that impacts on other parts. So, one cog of a machine affects another cog. The prevention model is important because of the over demand of much of our health and social care system. The co-production, because that is about ownership and local delivery and evolution of a social prescribing project, and the fact that it should be delivered with community groups, voluntary non-profit groups, that I think is where the strengths and skills lie. When it comes down to metrics, to come on to your second part of your question there, I think metrics have to be socio-economic. So in other words, they have to be led through the social gain, but there has to be an economic debate. The economics of it are that the successful schemes that are researched into the UK, and some of those globally, are investing £1 to save at least 2, if not more, sometimes 3. Not a lot more than that, but invest £1, save 2. And that's mainly because they offer an alternative to demand management. They offer a way of preventing people accessing and using those very scarce and expensive services in the public sector, in the NHS in the case of the UK. But if we just go back to the basics of what that value is, the value is about reducing demand, and there are real costs associated with people then not using those high-cost healthcare services. There is also a social value and an economic value in employment, making sure people are well, obviously at work, able to look after their families, has an economic value. These tend to be the KPIs or the high-level indicators which people use because they're economic. But I'm just going to make the point here is that it is as important to measure the very personal, the very human. Things like, are people more confident? Do they feel they're better in themselves? Are they safer? Do they feel more capable to opportunity? These things are as important as those economic indicators. And actually, those schemes that I've looked at in depth in the UK that have done the best have, as importantly, wanted to know the outcomes that were very much around people and human achievements. I'll finish with the prevention area of this is crucial. But for me, those impact models that have sustained themselves and done well and attracted further funding, alternate funding, which is not from the public sector, from corporations, from social investors, have been innovative. When I say innovative, they have developed some of those things which I've heard about, things like peer models of support. They have developed friendship networks. Isolation and often not having the opportunity to talk through your long-term health needs with somebody that understands them is actually quite an issue. And, you know, I also would agree with what I heard earlier around, you know, some of the delivery of social prescribing can be very innovative. It can be done outside. It can be done with networks of people in the open air, and that is in itself a joy, and people in very much joy. And we shouldn't underestimate that. The attachment or engagement with social prescribing is often about people feeling comfortable, feeling valued, and wanting to establish themselves within a group of people that mutually support each other. These things matter enormously in the future social prescribing models. I'll stop there, and I'm sure we'll come back to it with some questions later on.
Thanks, Lee. Yeah, we've had some comments and questions. I'll bring up the comments and questions later on as we go through the session. But I also want to make the point that Lee's mentioned here about the innovative funding models. And this basically, when we launched the Global Social Prescribing Alliance back in 2021, this was what we discussed. It was to come up. This was the basic mandate of the Global Social Prescribing Alliance, was to make social prescribing sustainable, to bring together the network globally, to be able to then leverage that network, to be able to bring in the private capital. And that's what we're doing. And that's why we've launched on our memberships. You'll see on the memberships, it's free for all voluntary sector and charitable organizations to join us, so that we can actually work as a collective to bring that financial support behind social prescribing. So we talked about the compassion, the trust, the building of the networks, the health literacy. So let me bring in, hopefully, Cristina. Her signal is okay at the moment, but Cristina in Portugal, you're very welcome. I have a question for you, which is, you know, how, it's for some reason, how do compassion and health literacy intersect when building trust in social prescribing ecosystems?
Thank you very much, Garrett. I heard Lee, and I agree completely. We need to invest on early prevention, but we need to increase confidence and trust, because when people has confidence and trust, this will be very, very important. So I have some notes, so I will read and I will speak. Just to reinforce that Portuguese Society of Health Literacy is a national reference organization on health literacy and provides know-how and tools and frameworks to integrate this compassion with health literacy into social prescribing and public policies. Concerning your questions and good questions, how compassion and health literacy intersects when building trust in social prescribing, we know that intersections in compassion and health literacy is central to building trust with social prescribing ecosystems. In Portugal, this interplay is increasingly recognized and fostered by Portuguese Society of Health Literacy, which plays a pivotal role in advancing a more humanized, equitable, and participatory health system. We are also, and we want to strengthen this partnership with WIS that give us strong ideas and strong ways to reinforce this social prescribing. So when we talk with the compassion and health literacy together, they foster relational trust, enabling respectful and inclusive dialogue between professionals, patients, and community actors, and influence public and policy makers that we must have the public policies. So I believe that trust in social prescribing connects individual with non-clinical services, for example, cultural, social, community activities to address social determinants of health. But I believe with Lee that trust and confidence are essential in this model, where multiple stakeholders, health professional, community, patients and workers and co-workers co-create solutions. Without compassion or health literacy, individuals may feel disempowered, may feel excluded, or skeptical in non-traditional care pathways. So Portuguese Society of Health Literacy acts as a catalyst for integrating compassion and health literacy into national and local health strategies. Our contribution in 4 points, and 4 main points, is capacity building. Portuguese Society of Health Literacy promotes training for health and social care professionals in relational with health literacy, communication, and compassionate care. On research and advocacy, it supports evidence-based policies that demonstrate the link between health literacy, compassion, and better health outcomes. Community engagement also. SPLS collaborates with municipalities, with patient organizations, with schools, with civil society, with health organizations to embed health literate environments where compassion and trust can thrive. And also development tools and models. We have the model ACP, assertiveness, clarity, and positivity. It's aggregate competences in communication that we use for non-violent communications. And this model facilitates the effective human-centered communication in social prescribing. So in Portugal, we advocate for a co-creation approach where the voices of patients, communities are central to this design, and compassionate listening and health literacy sensitive practice reduce stigma, enhance understanding, and support equitable use of resources. We have good examples in Portugal, the program in National of Elderly, from steps to embraces, that is physical activity for elder people with cancer. And this brings us very strong data about trust, confidence, passion, and especially the connection that we must have in people, with people. For now, I think it's enough.
Thanks, Christine. And I have to say, Christine has been pioneering this work for many years and has an incredible network across Portugal. We actually launched World Health Innovation Summit together earlier this year. We had an enormous audience, and with all Christina's help and support, and we're due to actually have a meeting later this year, hopefully with the minister in later this term. But let me speak to Lameck now. Lameck and I have been working together for a number of years. Lameck is doing, again, pioneering work in the community around cancer in Africa, in Kenya. Lameck has an incredible vision. He's also been supporting World Health Innovation Day. He set up, mobilized community activities around sort of social prescribing last year, set up runs, set up football events, really, this preventative approach adopted across Africa will release huge amount of opportunities in the future because they can learn from the legacy systems. They don't have the legacy systems. They can actually build a sustainable model of healthcare from the ground up. And Lameck, over to you, because I think it's important that you give the context here about, how do you see social prescribing being adopted and, the work that you're doing with World Health Innovation Day, for example.
Thank you so much, Gareth. Once again, I'm happy to join this conference. It's eye-opener. I'm very great receiving insights from the presenters here. It's a bit challenging when you talk about social prescribing in the developing countries, because it is something that most of people don't understand. Yet it's something that I can say it has been going on for a while and for some times, yes, because when I got into the cancer space in 2011, I realized that what I was really doing is just the same thing we are discussing here, social prescribing, and linking patients to where they can get assisted in terms of finances and also in terms of items needed for their medication and so on and so forth. But we realized that as the world is advancing, there are quite a number of things that needs to be looked into and also put in place. I want to echo what one of the presenters said, that in the previous presentation, one of the presenters talked about putting legal framework. Sometimes it's very good to putting in place policies and legal framework to guide most of these initiatives that needs to be implemented at the community level. So far within our organization, one of the things we normally do is try to link up patients, families, and also caregivers with the resources available around them, so that they don't strain a lot and they don't find it difficult to get access to the service that are required. And this is the reason why I joined Gareth, especially in World Health Innovation Day, to make to echo what Gareth is doing, especially in Africa, because it has a weight, it has a meaning, it has got it has a future. When it's implemented well and put in place, then our community will benefit a lot, because most of the resources we are trying to look from outside, we have them here. The only thing we need is to get energized and also to get information how to utilize the resources that are available here. So that is why I'm into this, and I'm also looking forward to mobilize the community for the forthcoming World Health Innovation Day in August. As I conclude, one of the things I can say is that such kind of platform really give us opportunity to network, meet people, and also to engage more, even outside the platform, because this is where we can get more information, get insight, and also get energized to continue building the network and also to continue putting in place what is necessary for our community. Thank you so much, Gareth, and thank you so much, everybody that is here. I'm looking forward to work with anyone that is willing to extend their services to Africa and also in Kenya. And just to finish, I can say that Kenya has really done very well in community health initiative, especially working together with community health volunteers, reaching out to the community at their doorsteps with some important health services. So we are in the right track as a nation, and also in the global network, I know we are in the right track. Thank you so much.
Lameck, just before you drop, like before we bring someone else in, and maybe just share with the group here, your sort of vision around cancer services and the work we've been starting to build, an impact project I've worked with yourself on, because I think you're a pillar of the community and you've done some fantastic work. Maybe just share in 30 seconds.
Okay, thank you so much, Gareth. I've been into the cancer space for a while. I understand the groaning and the pain that the community is undergoing. One of the things that we are looking at right now is to do more prevention, early detection, and then see how the management can be done well. You realize that where I come from, we only have one referral hospital that cover like almost the entire Western Kenya. So we've been trying to work closely with Gareth to put in place a place whereby we can offer palliative care services, because palliative care services is really, really in their need here in Kenya. Very few places that you can get such kind of services. So we are on the road with Gareth, working together to see if we can have a place whereby we can offer such kind of services and also bring down those services to the community. Yes.
Great, thanks for that, Lameck. So we've got a couple of questions that have come in, and I'll pop to. We'll come to Heidi first, Heidi and Camila, so that you can give some insights, because there's questions here around any tips, for lower middle income countries in terms of how they get started. And maybe I'll come to you first, Heidi. You're dealing with a lot of lower middle income countries at the moment, and we've had some initial discussions around how we can kick this process off. Maybe you could give some insights, and then I'll take Camila as well.
Yeah, thanks, Gareth. I think it's a great question. So I think, in general, I think social prescribing and nature-based social prescribing, it's relatively in its infancy in many of the low middle income countries, for sure. What I would say is that, as for any other countries, I would say that we first need to speak to the cities and the communities, because there isn't a one size fits all. So across Africa, even with, there's so much diversity across other regions with middle and low income countries. So I think there's a huge variation in terms of the context, but also in terms of the existing capacity. So we know as we've just heard from Lameck, there's actually an awful lot going on in terms of community organizations on the ground. And a lot of capacity there, and it's maybe more about understanding what the goals are, what the capacity is, how to sustain that, how to ensure quality and measure the impact. So I would say, first of all, our first step would always be to speak with the member cities who have an interest and build off of what's already existing. And I think, as was mentioned in, I think, Andy from Signal in the previous session was speaking about data. So I think really then also just using local data to understand the needs, understand what is there and how to best, think about establishing a program. So yeah, those would be my sort of initial thoughts.
Thanks a million, Heidi. Camila, bring you in. Go ahead, Camila. From your perspective, how do we build those networks? And
I mean, I agree with everything that Heidi said, but sometimes, for example, I feel like in low and middle income countries, it isn't a conversation that the public sector is having. So starting those conversations in the cities might sometimes be harder. So my first recommendation would be start with whatever you can. do the early wins. When we started in 3 medical centers, trying to convince others that this was relevant. And, that was okay. I would have, of course, liked to have started bigger, wider with public sector involvement, private sector. Well, we are private sector, but, wider private sector involvement. And, all we could find was 3 medical centers that said yes, and that they were willing to sort of start that with some local communities. And so we started with that. So it's okay to start small. It's okay to start with whatever you can and whoever's saying yes. We started, as I said, 2019 to do social prescribing. Just this year were we contacted by the public administration in our city saying that they think this would be something valuable to do within the whole system. And that's okay, because we've had our ways, and we are now doing it in many centers, and we can help others start it. And so I think one of the things is sometimes we want to do so much more, but we can't. So start wherever you can, and also be innovative. And I know Lee's going to talk about financing, but at the end, sometimes having that big financing to make it big is not going to happen at the beginning. So be creative in terms of how you're doing it. For us, for example, it's been crucial. Low and middle income countries are very innovative in how to solve issues because we don't have those big budgets. And so communities are always locally coming up with solutions, like Lameck was saying. There's already a lot happening. So start digging and tapping into those organizations so that the social prescribing doesn't become something that if I don't have the funding for the other organization, no one can provide. Start with what's there. And I am sure that when you look on the ground and really dig deeper, you're going to find a ton of resources of things already happening from the local communities that would make you have amazing networks of social prescribing without having to go to the full funding, which of course we would all be happy to go to. But I think it's something that we have to build up, especially in low income countries.
Thanks a million. So Lee, over to you. Start.
Right. Well, I'm going to give you an example, if I may. So large city in northern UK, and they have a navigator program for vulnerable people in their hospitals in A&E, and there was an awareness of a growing number of people turning up in A&E and urgent care. A lot of them were young people. A lot of them had ongoing repetition of issues. I'm going to describe them as mental health issues, but they were wider than that. And mental health is a big area where social prescribing can be extremely valuable. And actually, this example also applies to a large city in Australia, where they've done the same. So they noticed there was a lot of people turning up at A&E, very expensive, and obviously we want that service to be there to save lives and do the important work that it does. Now, why were those people turning up there when they have a long-term repeating issue? And it may have been particularly difficult, or in that episode may need to be managed. But in the long term, that person will increasingly return, increasingly utilize high-level healthcare services at great cost. So in this city, they worked through a number of initiatives locally. So this is an example you can draw from. They decided they would actually, having lost many of their family centres or youth clubs, they would reintroduce a couple of them, and they would have in those centres the opportunity for people to receive support of a very personal, not necessarily clinical, but as advice and support and awareness raising for many people who were utilising those high cost services. And these centres became, I suppose, support centres, networks, and very much used by the voluntary sector to host a number of services. Many of those services were talking therapies, talking about people's issues and concerns, and how it led into other things like not attending school, not being at work, many things that impact the whole society. They don't add any value to a community at all. So what in improving those, the community improvement was going to follow. Now, to get into some of the money around that, local business with a small grant from the public health side of the local authority. They only put in about 20,000 to get things going, 20,000 pounds. So then that was matched with business, corporations, retailers, people who were working in that city who recognised these issues too. And it built a fund. It built a fund of about £100,000, enough to run these 2 small community centres. And built around that, which I was very involved in, was how do we measure? How do we understand that impact? What is it actually? What's happening? So we started to look at that socially. Are people more confident? Are they back at school? Are they working? Are they training? We looked at all of those sorts of soft and hard measures, because some of those have got real value, economic value. Some have got much more of a social value. And in delivering this service, and it ended up being for about 250 families and groups. The value of that was £300,000. That was absolutely established. We were able to show that people were back at work, people were attending school, people were not going to the accident and emergency and the urgent care services, because they were getting their services in a much more local, socially prescribed method. And when I say socially prescribed, really what I'm saying, it was non-clinical. It was about people helping each other, and it was about support networks and understanding. Yes, there were some very sophisticated things going on, mutual support, help and listening. These things are incredibly valuable as prevention measures. And so we looked at that. We created the value of the savings by not going into our high cost healthcare services, by being at work, by being at school. And we looked at that as 3 times the value of what was invested. So it got to the end of the first year. And what we said to 3 organizations at that point, it was education in the public sector, it was a healthcare service. We said, could you, between the 3 of you, because it's very integrated, could you find a third each for this to continue? And they found a third of that 100,000. So they found a third of that. So second year, they're funding it, but we're still delivering the value to them through prevention and through earlier intervention. At least it was about £260,000 a year, simply because these services existed and they were preventing a recognized number of people from either attending healthcare services or, as I say, being out of school, not in training, not in work. And because we looked at that, we said, look, there's real value. So the next city I went to, I said, here's a model, here's how it works. And that was totally invested in by businesses and by social investment. No profit was put into it, and they put up the funds to develop again a community-led initiative, as I've described in the previous case. And now that's going on for its 3rd project. Now, what's at the heart of all of these projects is people helping each other and sharing some technical information, yes, but also sharing some of the issues that happened to them and why it was so important, particularly young people supporting each other. That is incredibly powerful. So, there's a very clear economic debate here. It costs £100,000, it saves 250. That's the reality. The local city, the first one we went to up north, they now fund that on a regular basis annually. It's a different set of people, but we had to prove it through the social investment model. So that model was not funded through the public body. And actually, what they're asking for is, can we extend it? Can we go for a 3rd and a 4th and a 5th community type model? And I think that is the reintroduction, because it never should have gone away, in my humble opinion, of prevention, of community-based health. And that initiative is now regarded as having a value of over £1 million for about £300,000 going to be invested into those 3 centres. Now, the bit that you'll be interested in is how you gain the social investors into that. Many of these social investors in these cities that I'm mentioning are local. They work there, they employ people there, they absolutely, one of them said to me, we want some of these young people and some of these people that we are helping to be our future employees. We want them to, you know, be in our communities, living in a prosperous and healthy way, not using our healthcare services in an illness-focused way. And that was from, you know, a business corporation. It's really impressive to hear when a retailer, in that case, starts to explain a public health model, and that's what they were doing. Now, there are several bits of machinery in place to have social outcome projects defined and governed in the way that I've described. And as I say, there's about 10 in the UK now and 50 across the globe. And I think there is a great opportunity to do more of this. And, you know, I'll stay away from the politics, as I said. The issue here is, this is do for self, communities really saying, we don't want that model. That's not working. What we'll have is something local that does support us in a very human way. We'd like that. And in a sense, they developed it themselves. And then the public organizations came in behind it and said, actually, yeah, this is good for us too. So it was a community-led, a democratized way of delivering a better outcome model.
Perfectly. I think that's exactly what we're looking to achieve by working collectively. I mean, I couldn't, yeah, you know, you're absolutely right. It's the purpose of this session as well, is to show, you know, everyone around the world that this can be done, that we have a framework. It's about working together. It's about trusting each other. It's about being collaborative. And I think, you know, I think it was Heidi that says, like, we have to bring everyone to the table. We cannot be excluding anyone. It's got to be locally driven. But then the support can come from those who have done this in the past and share that knowledge. So, look, we've got about 7 or 8 minutes left. Let's do a quick round robin for final thoughts and a sort of call to action. I'll start with Cristina first. Cristina, your like sort of final words and call to action.
It's me now. Okay. I agree with Lee absolutely, because first of all, we must ask people what they want. We have here in Portugal the mini assemblies of health, and we ask people what they want for social prescribing. This is the first step. And concerning the tech providers in social prescribing and the role of private sector, I will say that we must impact measurement. Maybe we can use artificial intelligence, machine learning, or big data to identify the needs and track outcomes and improve personalization in social prescribing. We must evaluate the return on investment also, and social impact metrics to justify funding and policy support. And probably in innovation and investment, invest in social innovation means in digital therapeutics, for example, well-being apps or community health platforms, prototyping of health literacy tools. We also agree that we must have corporate social responsibility. This fund or co-create community health initiatives and support vulnerable populations via inclusive design and equity-centered partnerships. So we can increase, and we are doing a work together and also with Garrett to strategic national leadership, capacity building and training, because people need training on this social prescribing, and to give evidence-based frameworks and policy influence, because without policymakers, we won't have public policies. And together with the WIS, probably we can contribute to build interoperable digital ecosystems and leverage data to ensure this equity, this personalization, scalability of interventions. and foster this culture of shared responsibility to involve more people on this. So I will finish with 6 points that we must have. Communicate benefits, making the training of people, increasing networking, influencing, acting, and then measure what we are done. Thank you.
Thanks, Cristina. Heidi, over to you for some final thoughts and words of wisdom.
Thanks, Gareth. I think Cristina summed it up extremely well. Just a couple of other reflections that came to me. So the first one, I think, for many of the countries that where social prescribing is not yet very extensive, I think maybe Camila made the point. I think it's really important first to make sure that people know what is social prescribing, really understand what the value is, so that we can then have those sort of in-depth conversations and really start moving to action. So I think that's one essential first step that I see. Then I think it's also the understanding that around the financing, which is really critical. So I think, and thinking beyond just the public sector as being the funders of healthcare. So I think in a lot of the places where I work, that's the sort of default thinking. We want some new health program and it's public sector, and although the private sector is playing a huge role, I think they're not really brought on board often. So I think bringing, the idea and straight away, I think the financing is critical at the very earliest stage of the conversation, so people can understand there's a return on investment, there's alternative means to look for financing these kind of approaches. And then I think, learning, I think maybe you just said now, that's really important. Like, we don't need to reinvent the wheel. So we need to tailor these approaches for the local situation and what the needs are. But we can also learn so much from which is, I think, what you're doing today with this summit, which is tremendous, is, learn from what has already been done, what has worked, and then adapt that together with the local stakeholders who know their own situation. And I think finally, which maybe hasn't been mentioned so much, but just sort of came to me as an added benefit, as for places such as South Africa, many low-income countries, the youth is a really critical piece, both in terms of needing these services, but also in terms of bringing, economic opportunities. So I really see a huge, really exciting potential there, how we can also think through these kind of services at the local level. How can we think about empowering the youth with engaging them, and economic opportunities through providing these kind of services at a local level.
Yeah, so let me just, on that point of job creation, because I think it's an important point that you raised, and this is all about job creation. And my estimates, I estimate if the current health system needs 80 million staff by 2030, and we're going to be about 18 million staff short, and this area is completely underdeveloped, we can easily we can on average create about 80 million new jobs. So there's the opportunity for you. So let me just bring Lameck in for some final thoughts.
Thank you so much, Gareth. One thing I want to say is that currently, as we speak, in Africa, we stand a better chance in implementing some of these. Especially, I want to echo what Lee talked about, social investment model. It's really important, especially for the young people right now, because in Kenya, we saw a few days ago, there was a uprising of young people coming out to talk with the government. So it's because of lack of employment and also lack of engagement. So the only way to engage them is to provide them with investment or financial investment where they can also get engaged. I think, yeah. And my part is that we are on the right track, and I'm seeing a better future, both for the elderly and the young people. Thank you so much.
Thanks, Lameck. Let's go to Camila. Final words.
I mean, I think that the way I would start it, if I had to, again, in a country like ours that are low middle income, I would say first start the conversation and start small. It doesn't matter. Just start with what you have and whatever you can tap into. Try to find those early wins. We've talked about a lot about young people today. I think that's crucial, but let's try to figure out what are those pain points for the community that you would be working with, so that it's easier to tap in things like Lee was saying, so that you spark their interest. If you're doing something that for them is relevant right now, then it'll be easier to get them involved. So what would be those early wins, those pain points for those key players? And then listen and scratch and see what's already out there happening, like the clubs that Lee was saying, or the community solutions that we have found here in Colombia of people already doing things for their neighbors, with their neighbors, that don't require a lot of funding because it's already happening, and start tapping into those. And then with that, you will build your case to make it bigger and grow, and then tap into all those other resources that Lee was mentioning. But start small and build your case with whatever's out there, using those major pain points around you, so that you can build that case that will bring all the others in. And as I said, we started in 2. Right now we have 60 medical centers in Colombia doing this, 7 hospitals, other organizations are coming, the public sector is coming along. But we started in 2019 with very small things. So, start somewhere, I would say that.
Completely agree. Lee, final thoughts?
Yeah, just very briefly from me, and it will build on some of what you just said. I joined a social prescribing movement not far from where I live, and it was for families. It was for families who have a range of problems. Most of those families are poor, and most of those families don't have access to a lot of things. And some of their lifestyle choices aren't great. There may be obesity, there may be substance misuse. And when I went along to the social prescribing, which was there, it was about family support. It's very well managed, systemic support, and families helping each other. And I know we haven't mentioned it, and at the end of the day, I'm very much a hard-nosed socio-economist. I want to know the cost and the value of everything. But when I went to this service, do you know what I saw? I saw respect, love, care. That's what I saw as social prescribing, and that's what they were doing. It was well managed. People were helping each other. That's not rocket science, really. But if you put it into the proper process, understand the cost and the value of that, you'll realize without it, actually other parts of our system isn't going to work. The higher cost of that critical or crisis type service that health and social care have to provide by law, they have to provide it. The reality is they can't, because there's so many people who get there. What was happening in the social prescribing that I went and sat in on was very much about respect and care.
But Lee, you make such an important point here, and I'm sure Heidi and other colleagues would agree with me. And I've sat on the other side. When you look at the hospital system, the reason why I joined the health service was to help people. That compassion, that love. That's why we joined the health service. But I think we all recognize that the system is under so much pressure now, and we need a new model. We need new ways of working. Hence the opportunity with Global Social Prescribing Alliance, the World Health Innovation Summit. These are platforms, but we can enable communities to take the tools to manage their own health and well-being. Social prescribing can be a big lever of that. Mm-hmm. Anyway, look, we've had a fantastic session. We've covered so much ground here. I'm going to take a break because we're back at 1:30 for the next session. I want to thank all my panelists for being here, everyone who's joined. By the way, the registration for next year's event is up. So people, if you want to register for next year's event online, you can do so now. So thanks to everyone, and we'll sign off, and we'll see you at 1:30 for our next session. Thanks, everyone. Cheers.
Thank you.